Thank you, Cindy. And thanks everyone for joining us today. The title of our webinar is Treatment and Prevention of Opioid Use Disorder, an Overview. Our presenter is Dr. Dennis McCarty of Oregon Health and Science University. Just a couple of housekeeping items for you all. The audio today will be broadcast through your computer speakers, so please make sure they're turned on and up. You can download the presentation slides at any time. If you look to the right of your screen, you'll see a bar titled Download Presentation Slides. If you click on Dennis McCarty Presentation Slides, there they are. You can also use the chat questions feature throughout the webinar to ask questions or add comments, but we will save the Q&A session for the end of the presentation. About the Great Lakes ATTC, we are based at the University of Wisconsin-Madison. We're one of 10 U.S.-based regional and 6 international HIV ATTC centers. We serve the great states of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And like all the ATTC centers, we're funded by the Substance Abuse and Mental Health Services Administration. This is a webinar series, and our first webinar is focused on the treatment of opioid use disorder. The series is a collaboration between the Great Lakes ATTC, the Northwest ATTC, the Pacific Southwest ATTC, and the Western States node of NIDA's Clinical Trials Network. As we mentioned, all the webinars will be recorded and available for viewing along with the PowerPoint slides.
Thanks, Maureen. And as I said, I want to jump back to that polling question, and then we have one to follow it. So if you folks don't mind entering your information, we'll see who's with us today.
All right.
We'll just leave it open for a few more seconds. But yeah, I can see a lot of folks still voting. Great. Thanks, everyone. I'm going to close it in 5 seconds. And before I do see that some of you are having issues hearing us, I am not hearing, just the volume is very low. I'm going to make sure that our presenter speaks up and into his phone, so we'll see how it sounds once we get going. So let me end this poll. And there you can see the results there. Primarily substance use disorder counselors and social work, human services. Great, we're glad you're here. Okay, and then quickly, the second poll. Which medications for opioid use disorder does your organization offer? And you can check all that apply. Great. Okay, I got about 5 more seconds to get your votes in. Right, and I'm going to go ahead and close the poll. And I think all of you can see the results there with the prevalence on buprenorphine and none of these medications. All right, that's good information. Okay, so Maureen, I'm going to go ahead and go back to the layout with Dennis McCarty, not Denise McCarthy. So my error, and let you introduce our presenter.
Thanks, Cindy. Our presenter, Dr. Dennis McCarty, PhD, is a professor in the OHSU-PSU School of Public Health at Oregon Health and Science University. Dr. McCarty works at the intersection of policy, research, and practice, assessing the organization, financing, and quality of prevention and treatment services for alcohol and drug use disorders. He serves as the co-principal investigator for the Western States node of the National Institute on Drug Abuse Clinical Trials Network. He is also a principal investigator for an evaluation of the impacts of Oregon's coordinated care organizations on prevention and treatment for alcohol and drug use disorders. You can read more of Dr. McCarty's bio in the pod that's titled Download Presentation Slides. Dr. McCarty, are you ready?
I'm ready, Maureen. Thank you for the kind introduction.
You bet.
And I'll get clicking here.
Dennis, this is Cindy. I'm sorry, I'm going to interrupt real quickly. I'm going to go ahead and mute all the lines. There is some background noise, and I'm not sure if there's others on the phone line that we have not broadcast. So let me do that, and I'll tell you when to start.
All guests have been muted. You can unmute your line by pressing *6.
Okay, everyone's been muted. Dennis, you can hit *6 to unmute yourself, and we'll check your sound.
Okay, Cindy, you should be able to hear me?
Yep, I hear you just fine. I think that's better. Thanks.
Okay, great. So the first thing I need to point out is that this is a presentation summarizes a paper that was published yesterday in the 2018 Annual Review of Public Health. You may want to download that for more details. As Maureen mentioned, the Western States Node of the Clinical Trials Network is supporting the preparation of this presentation, and we see this as a great opportunity to let practitioners know more about what the National Drug Abuse Treatment Clinical Trials Network does. And a lot of the research results that I'll talk about today were based on research conducted within the Clinical Trials Network. You also see my other support and the the studies that I've been working on recently. We've got 5 learning objectives. First, we're going to help you understand the historical context, the federal initiatives that have provided treatment for opioid use disorders. There's the U.S. Public Health Hospitals and the Narcotic Addict Rehabilitation Act, or NARA. We'll also identify the most effective therapies. We'll summarize limited access to pharmacotherapy. We'll explain the chronic nature of opioid use disorder and the high rates of return to use, and specify approaches to preventing opioid use disorder and the role of overdose education and naloxone distribution. Lost my clicker. So the big picture here is that opioid use is widespread, treatment access is limited. From the 2015 National Survey on Drug Use and Health, we know that about 97.5 million individuals in the U.S. used prescription opioids in the past year, and 12.5 million misused those opioids, and 1%, or about 2 million, met criteria for opioid use disorder. Note that about 40% of those with a disorder entered treatment, and that's actually a high rate of treatment entry. For alcohol use disorder, it's about 5 to 10%. And in addition, we have another 800,000 people who used heroin, and 72% of the heroin users are also using prescription opioids. So here's the context. If you go back, if you jump in the Wayback Machine and go back to 1900, opioids were common. They were over-the-counter. Morphine maintenance was common for people with an opioid use disorder. The 1914 Harrison Narcotic Act required physicians and pharmacists to register, pay a tax, and keep records of narcotics dispensed. The Treasury Department interpreted the legislation as prohibiting the prescription of narcotics to treat narcotic addiction, and narcotic in this context is any controlled substance. The Supreme Court upheld that interpretation in 1919, and federal prosecution closed the morphine dispensaries. There was no longer access to care for opioid use disorder. Arrest and incarceration became the preferred interventions. So what did they do? Well, they filled up the jails. There was no support for treatment. And in 1929, federal legislation authorized the construction of 2 narcotic farms. Lexington, Kentucky opened in 1935. Fort Worth, Texas opened in 1938. The Kentucky facility served everyone east of the Mississippi. The Texas facility served everyone west of the Mississippi. And these programs were co-managed by the U.S. Public Health Service and the U.S. Bureau of Prisons. Once you entered, you could not leave if you were convicted of a federal drug offense. You served your sentence in these facilities. If you were seeking voluntary treatment, you typically were completing detox and then leaving. The treatment was based on moral therapy. This was state-of-the-art at the time, and it just means that if you're out in a rural setting, you're working hard, you're living healthily, you'll recover. And it was an English model that was imported to the U.S. 4 to 6 months was the recommended stay, but most volunteers left after a 2 to 3 week detoxification. There was no aftercare following release, and data suggests that 95% returned to use, and most of the people being treated at the narcotic hospital were in fact heroin users. In 1974, the hospitals were closed, and they became federal correctional institutions instead. This is a picture of the Lexington, Kentucky facility. Again, this was where you were getting your treatment between 1935 and 1974. And here's a picture of the entire farm. There's the dairy cattle in the back. The women's facility is the smaller facility in the foreground on the left, and the big facility in the back has rooms for men and also equipment and machinery. They sewed their own clothes. It was, in fact, a closed community. Social rehabilitation was based on moral therapy. They also had a federal mandate to find a cure for addiction. And that opened an interesting chapter. They were using prisoners to test for addiction potential, abuse potential. And so prisoners were volunteering to participate in taking drugs for science. Generally, they did not find the cure, but they made some big strides. Methadone was first being developed there. Buprenorphine was first tested there. They made a lot of other important discoveries. In 1966, the Narcotic Addict Rehabilitation Act was passed, and this was permitting civil commitment for federal drug crimes. You would spend 4 to 6 months at the narcotic hospitals. You have received ongoing supervision and aftercare in outpatient settings, and this was the first federal funding for outpatient services. It was the first community-based funding for drug treatment, and they needed to develop a workforce, and the authorization was a gigantic $15 million per year. Not much, considering the magnitude of the problem. Another development was the development of Synanon and therapeutic communities. Synanon was a prototypic therapeutic community. Staff in recovery used confrontational groups to change residents, required 15 to 24 months to modify dysfunctional behavior, eliminate criminal thinking, and develop skills of daily living. Confrontations were dehumanizing, and dropout rates were about 70%. So again, not very effective. Contemporary TCs have eliminated some of the worst practices and have substantially reduced their lengths of stay. An important breakthrough was the development of opioid agonist therapy, methadone. It's a full opioid agonist. It's activating the mu-opioid receptors. It prevents withdrawal. It reduces opioid craving and use, improves employment and health, and decreases criminal activity. The trick here is that federal legislation still prohibits the use of narcotics to treat narcotic addiction. The prescription, it forbids the prescription of narcotics to treat narcotic addiction. And the loophole that methadone went through was that they did not prescribe they dispense methadone. President Nixon supported the use of methadone. He developed the Special Action Office on Drug Abuse Prevention, and they expanded methadone services and improved access to counseling, but the system was managed by the Drug Enforcement Administration. In 1995, the Institute of Medicine recommended less regulation. SAMHSA assumed regulatory responsibility and accreditation standards in 2000. So methadone programming has changed a bit over time. Opioid agonist therapy was first tested, or opioid agonist therapy is buprenorphine is another opioid agonist. It's a partial agonist on the mu opioid receptor. That means it's safer than methadone. It depresses respiration less, and in order to inhibit abuse, it's formulated with naloxone, which is an opioid antagonist. The design is, it's designed that if this is powdered and injected, the naloxone acts and sends the person into withdrawal. But if you swallow it under your tongue, if you take it under your tongue and absorb it sublingually, the naloxone is ineffective. However, to use this for opioid use disorders, it required changing federal legislation. Data 2000 created the waiver to the prohibition of using narcotics to treat narcotic addiction if the Food and Drug Administration approves its use. And physicians with a waiver may prescribe buprenorphine. Your panel is limited to 30 patients year 1, 100 in year 2. With specialized treatment, you can increase your panel to 275. And then nurse practitioners and physician assistants have just recently been approved to prescribe buprenorphine. They have additional training responsibilities. There are now sublingual, implant, and extended release versions of buprenorphine. When SEODAP was authorized back in the early 1970s, they were required to develop an opioid antagonist. Antagonists block the mu-opioid receptors and prevent activation. If you take an agonist, if you try to use heroin, the naltrexone will block its effect. It received approval in 1984 for the treatment of opioid use disorder. The oral naltrexone blocks opioid effects, but it's not an effective therapy. Daily dosing is required. Patients tend to have poor adherence to the medication. And extended release naltrexone was approved in 2010 for the use in opioid treatment. Recent trials comparing extended release naltrexone to buprenorphine find that patient outcomes are similar if the patients get onto the medication. Extended release naltrexone, however, requires 7 to 10 days without opioid use. That's difficult for opioid users to go that period of time to detoxify from the opioid use, and many return to use before getting onto the medication. How about pausing for a minute and just asking if there's any questions on the first part of the presentation? Please enter in the questions and comments period.
Thanks, Dennis. Maureen, did you have a question lined up? Okay, I don't see, the chat pod has been scrolling pretty fast. There may be a question in there, I just didn't catch it. I know some of you are having sound difficulties, and I don't think it's coming from our end as host. I think most people can hear, so I'm sorry if you're having speaker difficulties. We are recording, and we'll make sure you have the recording. All right, Dennis, I guess we can go ahead.
Sure. There's a question there. When naltrexone was being used in the late 70s, actually, I think that's probably naloxone. Naloxone is also an opiate antagonist, and it was developed and used for overdose prevention, overdose rescue. And it's not effective as a therapy because it's too short acting. Whoops.
Great,
let's go the right direction. So treatment access. We've got, what, 2 million people, 2.5 million people who need treatment. What kinds of treatment are available? If you look at the 14,000 specialty addiction treatment centers in the U.S., 82% are outpatient, 32% provide short or long-term residential care, 24% provide residential detox. Some specialty programs provide all three. Most, however, do not provide opioid agonist or antagonist therapies. The most recent data from the National Survey on Substance Abuse Treatment Services suggests that there's 1,283 opioid treatment programs. That's where you get methadone. 789 of them also use buprenorphine, and 337 had extended-release naltrexone. Another 3,000 programs provide buprenorphine, and another 2,600 offered extended-release naltrexone. The number of primary care practices that offer buprenorphine is unknown. Overall, only about 10% of the patients with an opioid use disorder receive an opioid agonist or antagonist therapy. And typical barriers are expectations for drug-free treatment, staff resistance, cost of the medication, the lack of prescribers, and prior authorization and utilization review requirements make it difficult to get patients onto the medication. And then the complexity of ordering and using extended-release naltrexone also inhibits use of that therapy. Here's a figure, a pie chart showing addiction treatment centers using the medication for opioid use disorder. You can see the majority are not using medication, and only a sliver, the red sliver there, are using methadone. Extended-release naltrexone is being used by about 20%. 9% are methadone, 2% provide all three, and 27% of the programs provide buprenorphine. So again, it's the services are available, but quite limited in scope often. When you look at the patients who are in care, 34% of the admissions to those 14,000 specialty addiction programs reported opioids as the primary drug, and opioid admissions have increased 60% between 2005 and 2015. 1 in 3 patients began opioid use before the age of 18. Most have had prior treatment admissions. Medicaid was the primary payer. About 50% of the patients being treated for opioid use disorder were being covered by Medicaid. Opioid patients tended to be white, and women were more likely to seek care for the use of other opioids versus heroin. Now, a big challenge is that return to use is very common. Patients first have difficulty tapering from opioids and return to use to prevent withdrawal. In 1943, an analysis of the patients at Lexington, Kentucky found that 13% were opioid-free 6 months post-discharge. Now our outcomes were similar, 14% abstinent at 6 months. And there's been a long-term study in California that's been following patients since the 1960s. 33 years after their initial civil commitment, 23% were living. Most are dead. 56% of those patients reported opioid-free urines. 14% were incarcerated, and 30% were positive for opioids or refused to provide urine. So we see that this is a chronic disorder, it's long-lasting, and treatment really requires persistent attention and returns to treatment. The Prescription Opioid Addiction Treatment Study was conducted within the Clinical Trials Network. They were testing the use of buprenorphine to taper people from prescription opioids. After 3 months of buprenorphine, nearly 50% of those patients were opioid-free. But after an 8-week follow-up, 8% remained opioid-free. Again, a rapid return to use. However, a 42-month follow-up suggests that a third were opioid-free, about a third were on agonist therapy and no other opioids, 8% were on agonist therapy and using opioids, and another third were still using opioids. So I think the treatments are getting more effective and more are being provided more effectively. The American Society of Addiction Medicine makes treatment recommendations for opioid use disorders. They recommend opioid agonist treatment with methadone for patients who need structure of daily dosing, opioid treatment with buprenorphine for patients with structure in their lives and without an alcohol use disorder or the use of benzodiazepines. They also note that you should not use oral opioid antagonists. The extended release formulation lasts for 30 days, and that would be the preferred medication, antagonist medication. The World Health Organization and the United Nations Office on Drugs and Crime also encourage opioid agonist therapy. And in 2017, the British Columbia guidelines, which have now been adopted as guidelines for all of Canada, discourage withdrawal from opioids without ongoing aftercare because of the overdose risk, and they promote the use of buprenorphine rather than methadone because of greater safety. In Canada, physicians can prescribe buprenorphine and methadone. One of the things we've looked at is what kinds of models are there for providing buprenorphine in primary care. Buprenorphine is potentially a breakthrough medication because it can be prescribed. You can integrate it into primary care, but there's still a lot of trial and error in figuring out how best to do this. The office-based care under close supervision of a waivered prescriber, what kinds of supports does the prescriber need? The buprenorphine HIV evaluation study provided treatment within HIV primary care, saw that it could be effective. The Vermont Hub and Spoke and Baltimore Collaborative induct and stabilize in an opioid treatment program and then support primary care to continue care using buprenorphine. The Massachusetts Nurse Care Manager model uses a nurse to facilitate patient management and reduce the burden on prescribers. We're now testing that model within the Clinical Trials Network. Project ECHO uses telemedicine to support rural prescribers. And then the Opioid Pain Guidance Group has a nice website that provides patients and physicians with web support, opioid prescribing guidelines, and they also host an annual meeting. And it's regional and pretty organic. To prevent opioid use disorder, the focus is often prevention of opioid overdose. Project Lazarus and the Oregon Coalition for Responsible Use of Medication are local initiatives using naloxone distribution, provider education, alternative pain therapies, and increased access to opioid agonist therapy. The CDC guidelines, Center for Disease Control guidelines reduce risky prescribing. Prescription drug monitoring programs are discouraging risky prescribing. DEA regulations have been amended to permit takebacks of unused medication, and the Presidential Opioid Commission has released its recommendations. For overdose education and naloxone distribution, Narcan was approved in 1971. It was originally formulated as intravenous and intermuscular injections, and it was limited to use by emergency departments and first responders. Local initiatives began doing overdose education and naloxone distribution using a nasal naloxone preparation, and the FDA has now approved the auto-injector and nasal spray formulations. But the prices have increased dramatically. The auto-injector has increased in price from about $700 to over $4,000. We can also look at some international treatment options. Heroin-assisted treatment is being used for patients non-responsive to buprenorphine and methadone in Europe and in Canada. British Columbia also permits daily slow-release oral morphine with observed dosing, and they host a supervised injection facility. with a photograph there. So we're beginning to wrap this up. Federal policy shapes and constricts treatment for opioid use disorder. Lexington and Fort Worth hospitals were the first federal funding for opioid use disorder treatment. The Narcotic Addict Rehabilitation Act provided the first federal funding for outpatient care. Legislation and regulation continue to shape these services. The Mental Health Parity and Addiction Equity Act requires health plans to treat behavioral health equitably. The Affordable Care Act made addiction treatment an essential benefit and expanded Medicaid. The Center for Medicaid and Medicare Services permits states to request a waiver from the Institute for Mental Disease Exclusion and to pay for residential care if they use ASAM patient placement criteria. The CARA, I forget what CARA stands for, but it expanded prevention, public education, and naloxone distribution, and the 21st Century Cures Act appropriated $1 billion for state demonstrations. The 21st Century treatment requires evidence-based practices, and in the 21st century, treatment for opioid use disorders requires evidence-based practices and integration with primary care to better serve its patients. And this is a series of this is a timeline on drug and social policy history. I'm not going to go through that. I've hit on some of the high points. This continues the timeline, and we're at the end of our planned presentation. So I'm open to questions and discussion.
Great, thanks, Dennis. I'm going to switch layouts here so we can see the chat feature at the bottom a little bit larger, and we'll ask Maureen to step in and facilitate some of the questions.
Thanks, Cindy. And Dennis, you did receive quite a lot of questions. Here's one. Participants asking, can you comment on the mood effects that we see in certain Vivitrol clients?
It's not my area of expertise. There are concerns that extended release naltrexone blocks opioid receptors, and therefore some patients report a lack of positive feelings, a lack of enjoyment. But others say that's not a problem. So again, I think it's going to be important to provide patient choice, look at all of the options available for patients, and at this moment in time, if you're not on an opioid agonist, you should be on an opioid antagonist.
Thanks. Thanks, Dennis. Our next question is regarding funding. Are there any challenges with funding for medication-assisted treatment?
Sorry, Maureen, I was trying to read the scroll. I won't do that anymore. Say the question again.
Okay. The question is, are there any challenges with funding for medication-assisted treatment? And I'm capturing the questions as they come in.
Sure. The challenges are who pays for it. If you're indigent, there is no money available unless the state has made specific appropriations for medication, the states or local authorities, to cover care for indigents. Medicaid has become the primary payer. Most Medicaid programs in most states have buprenorphine and methadone on their formularies. However, most Medicaid patients these days are in managed care programs, and each of the care managers has their own formulary, and often they do not cover buprenorphine and methadone or extended release naltrexone. Extended release naltrexone is the least affordable. It costs about $1,600 at the retail price, but there are programs to facilitate access to it, but it can be expensive. That's the quick summary.
Thanks, Dennis. Our next question is about buprenorphine. Can you clarify what happens if you inject buprenorphine?
There are two formulations for buprenorphine, Subutex, and these are the brand names, Subutex and Suboxone. Suboxone has 2 milligrams, has I think a 4-to-1 or 3-to-1 ratio of buprenorphine to naloxone. It's designed to be absorbed under the tongue, and in that case, the naloxone is deactivated. If you inject Suboxone, you crush it, get it into a liquid. The naloxone is supposed to kick in and prevent or precipitate opioid withdrawal. You can use Subutex, which is just buprenorphine. You could inject that without any adverse effects. I know that there are anecdotes of patients overcoming those abuse, the abuse deterrence formulations, but I think it's more uncommon than common.
Thank you. And here's a question about drug courts. Drug court prefers methadone over Suboxone since it's much better monitored. Suboxone is less preferred. Do you see this preference for methadone over Suboxone?
Drug courts have been pretty have not embraced medication for the most part. Under President Obama, the Office of National Drug Control Policy established regulations that said if you're receiving federal money for a drug court, you must provide access to these medications. And we've seen slow adoption within the drug courts. The value of buprenorphine is that it can be much more, it should be easier to obtain than methadone. Methadone is limited to about 2,000 opioid treatment programs. In large cities, that's not a problem, but in rural communities, you're not going to find a methadone program. And so that's where buprenorphine would be probably a preferred medication. Those are my thoughts on that issue. Yep.
Thanks. Here's a question about your pie chart on the use of medication-assisted treatment. Does this represent the U.S. only, and how does it compare to worldwide use of MET?
Yes, it's just that's specific for the U.S. It's based on the annual census of substance abuse treatment programs in the U.S. Worldwide, opioid use disorder is much less of a problem worldwide than it is in the U.S. Methadone programs can either be, patients can receive methadone either through clinics, like in the U.S., or through, in some countries, it's available as prescribed by the general practitioners. Canada probably has the most progressive policies. British Columbia is leading the world, quite frankly, in aggressive use of opioid agonist therapy. Currently in British Columbia, there's an initiative to increase the number of patients in primary care with opioid use disorders who are on medication from 50% to 90%. That's a number that far surpasses any efforts in the U.S. So we could be more aggressive. We could offer a greater range of medications, of agonists, and that may be necessary in order to get more effective care for patients who have been non-responsive to methadone or to buprenorphine.
Thank you. And another participant asks, are there factors why opioid use disorder treatment centers use or don't use the treatment medications?
Yes, I think some of the reasons why they're not using medications, many of them have no linkage with a primary care prescriber. They may not have a physician on staff. They may not have adequate training of staff to understand and to promote the use of medication. There's certainly a bias against the use of agonist therapy, a historical bias. I think when you look at the data, you're much better off prescribing or using methadone or buprenorphine. The death rates are much lower among patients on methadone or buprenorphine when compared to patients who are on abstinence-only therapy, drug-free therapy without supportive medication, and it's primarily overdoses related to a return to use is the primary cause of death. So I would, despite resistance to the use of medication, it is the thing to do in the 21st century.
Yep. And another participant asked, has anyone looked at adolescent prevalence? I believe that's of opioid use disorder.
Yes. I don't, off the top of my head, I don't have an answer to that. We could look at the National Survey on Drug Use and Health. There would be a breakout in that of 12 to 18 and 18 to 25 or so. So the data are available. I think there are concerns that the access to opioids has increased abuse within adolescents. And the Clinical Trials Network has done a study showing that buprenorphine is an effective medication with adolescents.
Okay.
Next.
Our next question is, I have individuals I'm working with that are in recovery from opioid addiction but have chronic pain. What can be done to help these patients manage their pain without relapsing?
I'm not a physician, so I'm probably not qualified to speak on that particular issue. It's a dilemma. Certainly, Oregon, for example, has now prioritized non-opioid therapies. The Medicaid plan has now prohibits medication prescriptions are greater than 90 milligrams. And so there are sort of policy strategies we can use to provide alternatives to opioids. Whether that would work for these particular patients, I think it's a matter of trial and error.
Thank you. And here's another one. Can you comment on the rate of relapse for someone after MAT versus non-MAT?
I like to use the term return to use rather than relapse. Relapse has sort of a negative connotation. Return to use is the nature of this chronic disorder. If you're not on agonist therapy, your probability of returning to use is pretty high. It may not require lifetime agonist therapy. Some patients remain on agonist therapy for their lifetime. Others find that as their life stabilizes, they can in fact go through a withdrawal process and no longer have a return to use. But there's always a risk of return to use. I was at a meeting in Canada, and a woman spoke about her son who'd been in recovery for 10 years, injured himself, was given opioids, and was now struggling again with his opioid use disorder. So there's a risk of return to use no matter how long you've been abstinent.
Yeah. Which method of medication is the strongest, methadone or Suboxone? And what's the difference between the two?
Well, methadone is a full opioid agonist. It's easy to overdose on methadone. Buprenorphine is a partial opioid agonist. It's going to depress respiration much less. And so from a sort of just a basic pharmacokinetics perspective, methadone is stronger. Buprenorphine is safer.
Okay. And another question about buprenorphine. Are there any studies identifying negative effects of long-term use of buprenorphine?
I'm just going through my thoughts about what studies have been done. The challenge is that it's difficult to do long-term outcome studies. And I'm just thinking through what I know. I think the best study is the prescription opioid addiction treatment study. which showed at 40 months follow-up that a third of the patients were opioid-free, another third were on agonist therapy and not using other opioids, and about a third were still abusing opioids. So I think that's pretty good prognosis given the historical rates of return to use.
All right, and here's a question about mental health providers. Will mental health outpatient clinics be able to provide these medications?
If they're licensed medical facilities, they can prescribe buprenorphine, or their physicians or nurse practitioners, physician assistants could prescribe buprenorphine. Methadone can only be used in opioid treatment programs, and the federal regulations on opioid treatment programs make becoming an opioid treatment program relatively difficult.
That's right. And is there a standard for applying treatment services with MAT, or can MAT be provided without treatment services, such as outpatient or intensive outpatient?
Clearly, the recommendation is to provide pharmacotherapy to support recovery along with counseling or other recovery program. I think ultimately it's a sort of a patient-level decision. What does your patient need? Some patients are relatively stabilized relatively quickly and actually prefer not to come in repeatedly for counseling. And it's probably better to have them do that and be stable than it is to force them off of medication because they're not coming into counseling. Unfortunately, those are rules that some health payers have implemented, that if you're not also getting counseling, you'll be forced to we will no longer provide your medication for you. I think, again, it's another sign of the stigma against opioid use disorders.
And
just one more thought, Maureen. We would never take a diabetic's insulin away because they ate cake. Why should we take medication away if it's helping somebody and they have a slip? So we should treat this like we treat other chronic disorders.
And here's a question about screening. Given the opioid epidemic taking place in any area, why shouldn't we be using SBIRT, that's screening, brief intervention, and referral to treatment, in our emergency rooms and primary care units to deal with this problem?
Screening, brief intervention, and referral to treatment is not an effective treatment for opioid use disorder. Studies in emergency departments, in primary care settings, find that simply screening for an opioid use disorder and even providing screening and brief intervention is not going to have an impact on most drug use disorders. It seems to be effective with alcohol use disorders, but probably for those who have less severe disorders. What is now developing is interest in using screening and brief intervention for problematic use of opioids in order to prevent escalation into opioid use disorder. The research is just beginning. We'll have to see if that becomes an effective intervention for preventing the development of opioid use disorder.
All right, and let's see, we have another question. What has been found in research so far, and what are your thoughts that are important when implementing buprenorphine treatment programs to improve retention?
So I would, a couple of thoughts. By treatment program, do you mean primary care? Do you mean specialty addictions treatment? The answer is going to be different. The specialty addiction treatment program can be effective. It can use buprenorphine and extended-release naltrexone pretty effectively if they have a physician who supports the use of medication, if they train staff to be supportive of use of medication if they adjust their workflows so as not to delay the access to the medication. If you're talking to patients, you start talking to them on day one about what medications might be useful for to support their recovery. You also have to talk to the family because the family needs to support the use of medication. We've just completed a study in the Medication Research Partnership. It was published, I think, last year in Journal of Studies on Alcohol and Drugs. And we found substantial improvement in access to in the percent of patients receiving medication. At the beginning of the study, it was about 10%. 3 years after we worked with programs using Niatex-type interventions, it was over 35% of the patients with an alcohol or an opioid use disorder were successfully inducted onto medication. For primary care settings, the workflow issues are more complicated. It's a busy environment. The hub and spoke model, Vermont's hub and spoke models, Massachusetts nurse manager model seem to be the most effective approaches to managing buprenorphine use in medical settings. And so that's where I would look for guidance to begin with.
Thanks, Dennis. Let's see. Here's another one. Should addiction be treated just like other chronic illnesses or just like other chronic mental illness?
For many people, problems with alcohol and other drugs are chronic disorders. They should be part of primary care's assessment. When you come into primary care settings, what's your full health history here? What's your history of alcohol use? What's your history of opioid use? And then the physician can say, Dennis, your drinking's up a little bit. It's going to be affecting your health. The physician can be making persistent interventions. I prefer not to talk. I prefer talking about screening, persistent intervention, and treatment as needed, or I call it the SPIT model, as opposed to SBIRT. But not many people are doing that.
Okay.
Tom McClellan has a nice paper from a couple years ago outlining a chronic care model for opioid use or for drug and alcohol use disorders. We should track that down and share it with your audience as well.
Yeah, we can do that. Here's a question on use of MAT without counseling. How would you suggest monitoring medication-assisted treatment use if not through counseling? MAT has street value and has a history of being diverted. What are your thoughts about this?
From a public health perspective, it's better to have more access to the medication than less access. The street diversion occurs. It's primarily used to prevent withdrawal. It's not being used for euphoric effects. So I'm from a public health perspective, I'm less concerned about widespread access to buprenorphine. Should it be done in collaboration with a counseling program? Absolutely, but not everyone is going to tolerate those kinds of requirements. And that's my only caveat is that we should be open to alternative models and alternative approaches to care. We need to find the care that works best for the patient. I see that. Yeah, I see on the bottom of the chat there's a link to the Tom McClellan paper.
Yes, thanks, Kelsey. We will. I'll see if we can post that as a PDF before everyone leaves. And here's another question. What are your thoughts about using technology to help treat substance use disorders in conjunction with MAT and counseling?
Absolutely. The Food and Drug Administration has approved its first digital therapeutic. It's a program of CBT that was tested within the Clinical Trials Network, and now has FDA approval. It shows that the internet technology, web-based technology, can be effective, can support recovery, and absolutely should be more available.
Very good. Here's a question about stigma. How can we best destigmatize addiction?
If we had an answer to that question, everything would be easy.
Yeah.
I don't know. I think integrating addictions treatment into primary care could go a long way to help. It's now in a specialty care sector primarily. You know, the stereotype of addiction treatment is you're going to spend 30 days at the lake, you're going to come back sober, and you're going to live your life happily ever after. We know that for some people that model works, but that's no longer the models of care that are available in the 21st century. So I think we need to integrate more with primary care. We need to be willing to use medication to support recovery, and we need to look at sort of patient-centered care. What is the care that's most effective for this particular patient? And each of us has a different path to recovery.
Thank you, Dennis. There's another question that's come in about heroin and overdose potential. Is it more likely to happen by nasal or intravenous use?
Well, clearly, intravenous use is much riskier. That's where the high risk of overdose is.
Very good. And I'm just scrolling through our comments. I think we've covered all the questions that have come in so far. And we have time for a couple more. I see that we have some participants typing.
Sure. While they're typing in, I'll just remind folks that we are offering NADAC CEs for this webinar. And about a week from today, you will get an email with a link in it. And you'll click on that link and enter your email address, and your certificate will appear as if by magic, and you'll be able to download or print it. And I'll give this information again. Okay.
Maureen, I'm seeing that.
Thanks,
I'm seeing that Charles is asking about reform of methadone regulations. I think that's unlikely. Methadone is the most highly regulated form of medication available. Historically, it's been regulated as sort of these freestanding independent clinics. They're always located in the best parts of town. There's a lot of stigma attached to them. I think there could be more effective models of care than the typical methadone treatment center, but I don't think we're going to do away with them because they are effective for some patients. I think the alternatives are greater access to buprenorphine, and if you're building a system of care in the 21st century, I would certainly build on buprenorphine and other agonist therapies. Take a look at what British Columbia is doing. It's interesting to see their work.
Thank you. And here's a question from Andrea. I want to touch on the concern of individuals remaining in treatment indefinitely. A patient that suffers from chronic pain that has burned bridges for treatment via other avenues will return to the street if not for MAT providing addiction treatment services with the secondary side benefit of pain management. Harm reduction is key.
Yes, that's absolutely true. Not every patient is going to have the same recovery. Some patients are going to be chronic patients. Others others will recover spontaneously. They'll make a decision not to use anymore. We cannot yet explain what's the difference between those two patients. Some of it may be genetics, some of it may be brain development. These are the challenges for the next cadre of researchers.
Thanks, Dennis. I see we do have multiple attendees typing. There's a lively conversation going on. Definitely sparked a lot of ideas, Dennis.
Well, I'm glad to see that. There's certainly a lifetime of information out there. And it's challenging to figure out what's the best approach, what's the best way to do it, especially if you're a family, if you have a family member who's struggling with these concerns. I think the good news is that treatments are effective, treatments are increasingly effective. Don't give up hope. Increasingly, we're building a healthcare system that can address these issues. A big development in primary care settings is hospital-based consulting services. You know, the patients that are costing the hospitals the most time and resources are often patients with a history of alcohol or drug use disorders. And so consulting physicians are now certified by the American Board of whatever. They are addiction specialists, and these specialty programs are working within the hospital environment to link patients to primary care and to link patients to ongoing specialty care. And they're having a positive impact. I think if we now extend that kind of model to emergency departments, if we extend that model to primary care settings, we can be much more effective with the current treatments that we have.
Thanks. I have a question for you, Dennis. I noticed that there was quite a number of participants who indicated that they work at organizations that don't offer any medication-assisted treatment. What are some tested ways to make that bridge, maybe overcome resistance to use of MAT in a treatment organization?
Well, again, it starts with leadership. Leadership has to say, we support this. Leadership, again, in the study we did with the Medication Research Partnership, programs told us they're losing patients because they don't offer medication. They wanted to begin using medication. Some cases they had to replace their medical director. Other cases they brought in training. The people at Alkermes who manufacture extended-release naltrexone are glad to provide training and support for programs that want to begin using extended-release naltrexone. The whole the NIATEX approaches to improving to organizational change, test a change, test it small, to use rapid cycle testing to make changes in your workflow that improve access. If they don't improve care, go on to some other change. Those are the kinds of strategies that I have seen work effectively over the past 18 years now.
Thanks, Dennis. I think that's true, that there's more and more field-tested approaches that are working.
In fact, Maureen, we should plug the niatex.net website. It provides a ton of resources on improving care in specialty addictions treatment programs. It's being generalized to other settings as well. And there's a whole section that was developed under the Medication Research Partnership on the use of medications. So there's lots of good detail there.
I'm typing that in as we speak. And I'll also add a link to the section of the ATTC network website that's dedicated to medication-assisted treatment. And this is all practical information that counselors and organizations can use to get started.
Correct, and you might ask them to subscribe to your various blog services.
I will certainly do that. Let's see if we have any other questions coming in. Let's see. There's been an exchange of links of articles that you mentioned, Dennis. So we'll
Good.
definitely be spreading that great research that's coming out. And we've got several thank yous, Dennis. We've got, someone's mentioned SAMHSA Tip 43. That's addressing questions on how to stabilize on MAT.
Yes, we're getting some great resources, and I just want everyone to know, too, that the recording of this webinar will also be made available, and the links in the chat feature will be live. So I'm adding them up here to a few of the pods, but we don't want you to lose any of these resources that people are so kindly adding. We'll find a way to make sure you can still get them.
Terrific. Well, I'm glad people have enjoyed the presentation. I've enjoyed being able to share the information, and you know, if I'm certainly available for another 30 minutes or so.
What we'll also be doing as a follow-up is we've gathered all the questions, and I'm going to tap your time again, Dennis. We'll create a quick one-pager with answers to the questions that have come through this webinar. That'll be posted on the ATTC Network website.
Okay, great.
We're getting a lot of thank yous, so maybe we can give people a little bit of their afternoon back. If you want to end a few minutes early, I think we should give it about another 30 seconds to see if some more folks have questions. Okay. Well, I am going to go over the CE, how to obtain your CE for this as soon as we wrap it up, and I'll switch to the closing layout. You guys ready? I think we've done a good job.
I'm comfortable.
Okay.
Thank you.
A lot of passionate people today. That's just awesome. Very engaged. All right. We do have one final polling question that we'd love your, wow, I already have that open. People already started voting. This is of the following webinar topics on medication-assisted medication treatments for opioid use disorders. Which would you most like to see? So you can pick up to 3 or, and I see a couple people are already adding suggestions into the chat pod right there, directly below it. I'm also going to leave this webinar room open for at least 5 minutes post-webinar, and our presenter can jump off, but you might want to scroll again through the chat pod and find any links I may have missed. You can download the slides. You can still put suggestions into the poll and whatnot. So don't feel rushed. We won't shut this room down as soon as we end the webinar. And I will reiterate, in about 1 week from today, maybe sooner, you'll get an email from me, Cindy Christie. My email address ends in umkc.edu, but it'll be apparent that it's from the ATTC, and it will contain a link. You will click on that link, type in your email address, and choose the training that you went to, which is today, and I'll have the date and everything, and your CE certificate will pop up. I did hear some folks asking for a certificate of attendance. If they want that, I can actually do that too. So you'll get to choose once you get that link. Choose whether you want the certificate of attendance or the NADAC CE. We'll make those both available. And Maureen, we have plenty of people registered for today, so I think we can send an email out to all registrants and attendees that will have the recording in case you want to share it with your colleagues, We'll also put the PDF version of the slides in, and we may end up with an FAQ for this webinar. Okay?
Yeah,
well, all
thank
right.
you so much. And thank you, Dr. McCarty.
Okay.
Yes, big thank you to our presenter. And I apologize for, again, saying Denise McCarty in the slide. Spelling is not my thing. Again, I'll say we can say goodbye, but this room will stay open, so don't feel like you have to rush off in case you want to get some more of the information. So Dennis, Maureen, have a great afternoon. I hope we do this again soon.
Sure.
Thank
Thanks,
you,
Cindy.
Cindy.
We'll be in touch.
Yeah, and the audio portion's going to close now, but again, we'll be here for just a little bit. I'm going to hang up the phone. Bye, guys.
Okay. Bye-bye.
Bye-bye.